All right, well, welcome to all the delegates today, whether it's morning or afternoon where you are. You're very welcome to the Cardiac Data Dashboard launch. I'm John Goodfellow. I'm the clinical lead for the Wales Cardiac Network, and I'm a cardiologist. And my co-presenter is Sally Cox, who is the Principal Specialist for Information at Nhs Wales Informatics. And Sally and I have worked together in the past. Now, the structure of the launch is going to be a short introduction by myself, leading into Sally talking about how the dashboard was developed, and then, hopefully, technology allowing, Sally's going to do a demonstration of the dashboard as to what its functions currently are. I would like to say at this point that this is very early days for the dashboard, and it's evidence of or proof of concept type of display. We are very excited about the fact that we're able to do this, actually get the dashboard up and running, but we now know there's going to be a lot of work done going forward in developing it further to refine it to answer the questions we really need to get answered. So I think if you're happy with that structure, I'll start with a short introduction and hand over to Sally. When she's finished with the demo, if there's enough time, I'll come back and do a few more slides. Then we'll have some questions from the audience. So can I have the next slide, please? So the background to this begins with something we did a few years ago. It's the Cardiovascular Atlas of Variation, and it was a value-based program which we set out in Wales. And the first area we looked at was cardiovascular disease. Click. The Atlas was intended to look at the way in which we manage cardiovascular disease across Wales. We looked at risk factors. Click, please. We looked at the main conditions that resulted in hospital admissions. Click. So that was acute coronary syndromes, heart failure, and atrial fibrillation. And what the Atlas showed us that there was across Wales unwarranted variation in the delivery of care. There was inequity of access, and there was a lot of waste in the system. And one thing we did, which was, I think, different to traditional atlases that have been produced before this, was to actually look at the costs of hospital care. Click, please. Sorry, it's difficult. I'm doing it remotely. And keep clicking. But what the Atlas also showed us, and which is relevant to today's presentation, is the data that we were using. This is routinely collected data that Nhs Wales collects on patients, either in the primary care setting, which would be the family doctor, GP, or whether it was in the hospitals, the district general hospitals, or the specialist tertiary hospitals. The data quality generally was of poor quality. Sometimes it was very good, but we also had areas where there was very poor data. Click, please. But with Sally's help, because she was involved in this project, the data was improved using a technique of data interlinkage, which we'll expand on in the next section, segment. Click, please. Just a couple of clicks. One of the things that was notable, though, that at the time we did the Atlas, which it was published in 2019, so this was data from 16, 17 and 18, there were very few areas in which we were collecting patient-reported outcome measures. And now that's something we've worked on since, and we are increasingly capturing patient-reported outcomes. Next slide. So in terms of data quality, this little schematic shows all the hospitals in Wales as the black dots, and all the cardiac audits we do, the national audits, are sent currently directly to London to NICOR at Barts Health. Our proposal now is, because the data quality for our audits is not optimized, is to send this data into our national warehouse for data. It's called a national data repository, where data interlinkage will be performed on the data, and the data then will be quality assessed and assured by a hospital clinician before it is sent to London. So we'll package all our data and send it to London, get it all back. The advantage is that the data we send is of higher quality, and the information we'll get back therefore will be of higher quality. One of the shortfalls we have with all of this, and I think it may be common to anybody working in the UK, is that we are working on paper-based records and then transposing paper to electronic record, usually retrospectively. So several clicks, please. One of the things we are in developing at the moment is an app so that all our inter-hospital referrals are done on an app for patients with an acute coronary syndrome, as an example. And that would extract all the data we would need for the national audit. So it's automatically delivered once. There's no reworking involved, no retrospective analysis of notes. The other thing which is exciting is NICOR has moved from annual reports to quarterly reports, and during the COVID pandemic was able to deliver weekly reports. Now that would be absolutely ideal for quality improvement, which is where we are driving our services with a value-based lens on. Next slide, please. So before handing over to Sally, just to say within Wales there is health policy, a Healthier Wales, in which there was a commitment to develop value-based healthcare as a way of planning and delivering our services. And underpinning this is the need to create a data-driven system and to make that data accessible to those who need it. And it needs to be accessible in a way that it's usable information. So it helps you to deliver direct patient care. It helps with the service planning. And as I mentioned in the previous slide, it helps us with quality improvement methodology. So that, in a nutshell, is how we got to the position where we thought we need to use these techniques and try and deliver a dashboard for our cardiac activities. And what Sally, I'm going to hand over to Sally now, but what Sally's going to do is explain the journey that she's undertaken to get to the first iteration of the dashboard. And I'll stress again, it's the first iteration. It's very, very early days, but we are excited and we need to get much more clinical involvement now in looking at what it is we need the dashboards to deliver for us. So it's my great pleasure now to hand over to Sally Cox at Nhs. So over to you, please, Sally.
Thanks, John. Okay, hi, so I'm Sally. I lead the Value and Health Analysis team at the Nhs Wales Informatics Service. So a little bit about Nhs. It's a national organisation. We support the health and care technology used throughout Wales. We collect data from numerous sources across Welsh healthcare and maintain a range of national databases that cover secondary care, births, deaths, child health and more. So the role of my team is to use the data collected nationally and to produce products to support the National Value in Health team. To date, the team have created data visualizations to support direct patient care, showing individual PROMs trajectories embedded into the patient electronic record, and we've produced 3 outcome data dashboards to support service planning and quality improvement. These products make up the Value in Health products. So the heart failure dashboard is the second in the series, and the first, the lung cancer dashboard, was released in June last year. You may have seen Dr. Gareth Collier earlier today delivering a session on how he uses the dashboard, how it can help him in his daily practice. So as part of Value in Health Week, we're also launching the knee dashboard on Friday at 1 o'clock. So that there's still time to sign up for that if it would be of interest. But we are going to be putting all of the sessions onto our new website shortly if you've missed any. So the data dashboards, as John described, are aiming to triangulate case mix, outcome and costing data. This first release of the heart failure dashboard brings together linked data from some of the national databases to show that what we can do nationally. But this is going to be an ongoing learning process, and we now need actively involved clinicians and expert users to sense check this data, and we hope to evolve the dashboards then with an agile and iterative approach to development. Further releases will then include additional data, functionality and analysis guided by this expert reference group to produce something that's useful with reliable information. So I'm now going to talk about a little around the challenges we faced in bringing together the heart failure outcome and activity data from across Wales before carrying out a demo of the phase 1 of the dashboard. Next slide, please. So this slide shows a patient's journey through Nhs Wales. In determining what data is required to create a dashboard, we've tried to take a step back and examine the complete patient journey. So the slide showing a patient's passage through the NHS from an information point of view in terms of data sets that the patient might interact with along the way. Our intention is to support improvement of outcomes, and so to do this we need to bring together all available data to provide a whole picture and to support the service in identifying any variations in care. The digitisation of these services and joining up of local and national systems in recent years have enabled us to access more and more of these data sets to provide a more complete picture of the patient's journey and start to understand differences nationally. Next slide, please. So this is a rather busy slide. So it's showing what data is actually available nationally at a patient level for linkage. The fact that it's busy provides quite a positive view that we do collect an enormous amount of patient level data nationally. However, these data sets are often set up for specific uses, and using them for different purposes can sometimes lead to flaws in your analysis. So we have lots of this data, but turning it into real information is the struggle and is the reason why we need our expert reference groups, as they are the key to making these products useful. So these patient level data sets can be linked together using patient NHS number to bring the journey to life. In addition, I've also highlighted in yellow some of the summary level data sets, which may be important in understanding outcomes. But it must be noticed that data quality and completeness can vary considerably nationally with some of these data sets, and we rely on our data standards teams to drive improvement here. So the 3 blue highlighted areas represent the 3 core data sets that are typically triangulated to determine value. We've recently acquired some patient level costing data into the National Data Warehouse. There is a session on Wednesday utilising this data for diabetic patients from the FDU and Dr. Julia Platt. We also have some PROMS data, however, collection is patchy nationally and is for certain clinical areas only. As John described, the clinical outcome data in the form of audit and registry data is not currently collected nationally for heart failure in Wales. Given that these data sets are so fundamental in supporting a data-driven approach in Wales, we've started a journey to enable this data to flow nationally to feed the data dashboards, which I'm going to describe shortly. Next slide, please. So specifically now for the heart failure dashboard, challenges that we've faced around obtaining outcome data. So the registry data is not collected nationally, so it's submitted locally to national registries. The National Institute of Cardiovascular Outcomes Research and NICOR manages the heart failure audit and 5 other cardiovascular audits. Health boards currently submit directly to NICOR using a web portal and receive a report back on where they stand nationally, typically 12 to 18 months later when the report is published. But we want to change this in Wales, as John was was alluding to earlier, collect this data nationally so that health boards can assess their compliance periodically. In addition, we want to reduce this enormous burden of information gathering by pre-populating fields with national health data and submit then to audit once for Wales. So for this first phase of the heart failure dashboard, we've been able to use 2 years of audit data. This was obtained through our Cardiovascular Atlas of Variation project. We're hoping that this data will be updated to more recent data once the data begins to flow nationally. So for those of you who don't know, PROMs are questionnaires that have been designed and tested with patients and clinicians for specific diseases such as heart failure. So these represent the patient reported outcomes that we are hoping to include. So they look for changes in patients' health pre and post treatment and over time to understand quality of life. So there's nationally agreed validated PROM tools for heart failure. These are the Kansas City cardiomyopathy questionnaire and the patient health questionnaire. However, we have multiple platforms locally in Wales that have varying degrees of integration with their local systems. So coupled with a lack of standardization, data flow is an issue on these platforms. Next slide, please. So on a session on Wednesday, tomorrow now this week, we're going to provide a more detailed view into the data standards work that we're currently progressing to support the data flow of audit data and PROMs across Wales. But in summary, this slide just shows that a Welsh Health Circular was issued on the 4th of March this year. So this is a mandate from the Welsh Government for the data to flow from the health boards, the audit and the PROMs data to the informatics service to feed these value in health products. As data is not routinely submitted, we then issue a set of what we call DSENs, which are data standard change notices, to the health boards and trusts, and this will provide the detail around the data submission requirements of the data that they now need to submit to us. So we have an assurance process through WISB, the Welsh Information Standards Board, to around the requested new data flows, and in June this year they've agreed to the outline process. And we have proposed a phased approach to the development and implementation of the necessary new data flows in order to ensure the delivery of the priorities set out in the Value in Health programme, and also due to resources available both locally and nationally. So this first work has now started with the development of a standardised process for central collection of knee arthroplasty audit and PROMs data. And we've got the first meeting of our stakeholder group to review these draft notices later this month. Once we formalise the knee outcomes data flows, this will act as a blueprint for other clinical areas, and it's anticipated that heart failure will follow. Next slide, please. Okay, so I'm going to show you now phase 1 of the heart failure dashboard. Really, we want to show the value of high quality data for healthcare improvement. But as John said, we're not there yet, and we've got a long way to go. But now we've got the product and the technical ability to link the data nationally and visualize in a format that's available to all in Power BI through the NHS Wales Microsoft Enterprise Agreement. The next stage now is that we need clinical engagement to steer this development, to create meaningful analyses, and to realise the value of putting the data in right at the start. Okay, so the data sets that have been incorporated into the first phase are outlined above. Hopefully this will raise lots of questions about the data, and we also hope to provide some insights around good practice and variation in care. As I said before, the dashboard's created in Power BI. It will be made available today now, as this is the launch. This will be available at a summary level for all within NHS Wales. And the dashboard will be available at a more detailed level with further filters for those with the required level of access to view patient level and low level data. And this will be through heads of information or local guardians. So please bear with me. I'm going to open up the dashboard. I'm slightly worried that the speed of the dashboard may be influenced by the number of people on the call. So I'm just going to open up the first page and show you what the interactivity, and then switch back to slides then to carry on with the rest of the demo. Okay. There we go. Right. Live. This is the contents page first then of the dashboard. This just gives a quick overview of what you can expect to find on each page. If I click on to the next one, let's see how this works. See how quickly it loads up. Okay, it is going to be quite slow, so I will flick back to slides now in a minute. But you can see the interactivity. So this is the National Heart Failure Audit Report Summary. It provides an instant snapshot, a visual snapshot of each of the health boards and where they are with regards to audit, providing 10 key indicators. As I described earlier, currently the latest data we have is 2017-18, but hopefully this will get more up to date once the data starts to flow to the NDR. So this is the admissions page. The slide shows an overview of admissions by age and sex, specialist input, and by specialty under which the patient was treated in hospital. A highlights section pulls out the key metrics. So we've got this highlights down here, pulling out the key metrics, as such as the total number of admissions and the overall percentage of patients who received input from a consultant cardiologist during their admission. We can also view these metrics by provider. So we can click here to compare the indicators nationally. Well, you will notice we have anonymized the information within here, just in case we show anything that may be low numbers or sensitive. Okay, I'm going to flick back to the slides now, as this is going quite slowly. Okay. Okay, so this slide here, the admissions, we're back to the admissions, but I just wanted to show how interactive this could be. So we've got filters down the left-hand side of the page that the user can use to explore the data and slice and dice the data as required. You can also click anywhere in the dashboard to filter to any area of interest. For example, if you were interested in patients only treated under general medicine, for example, you could click this bar and all the windows would update accordingly. Sorry. Okay, so this shows the screen then with that general medicine specialty click there. So everything has changed, but you might also want to do this for age groups, for example, by using the page filters down the left hand side. For example, if you were only interested in patients who were over 50, you could select those, and the screens would again update just for that age range. Okay. So this moves on. This is one patient history. So it's medical history of patients. And we can examine the effects of comorbidities on length of stay here and mortality by triangulating audit data with secondary care data and the mortality data set from the Office for National Statistics. So this can be particularly useful when examining survival over time following treatment. This is a length of stay slide. So the dashboard aims to allow exploration of data for the purposes of examining variation. And length of stay in hospital is a good example where lots of variation can be seen. But however, there's often valid reasons for this local variation, which we hope will be guided by our expert reference group. It is hoped that the variation explored within the dashboard, that we can see some of this variation within the dashboard by playing around with the filters. So overall then, this slide shows a detailed view of the median length of stay over the last 5 years, and you can see that in the bottom left visual that length of stay has remained pretty consistent in Wales over the last 5 years at 7 days. However, you can see the variation also between health boards, between 6 and 10 days, and throughout sites, even more variation between 4.5 days at the earliest, the shortest, and 12 days at the longest. So that represents nearly a threefold difference. So once registry data is flowing, linking this data and PROMS data will hopefully provide a much fuller picture. So this is 30-day readmissions following heart failure admission. Again, we can see the variation across the health boards between 7 and 11%, with an average of about 9% in Wales over the last 5 years. Readmissions are more likely in an older age group. We can see from the bottom right visual. They've remained stable at around 9% for the last few years, with a drop now in this recent data in 2020. But then that's not surprising due to the pandemic, which has not only affected the number of admissions but also caused delay in coding activity. So that said, coded data is included to the latest week. As the admitted patient care data set from which this data comes has recently moved to weekly submissions in Wales. So overall, there appears to be a trend in the reduction of admissions as the length of stay increases, although this can be variable in some health boards. We can see if we click here on health board 2, it kind of goes up and down a bit. But we can still see overall that an average length of stay with a 30-day readmission is shorter than for all spells. So this slide looks into multiple admissions. So this is defined as a patient who's had 3 or more heart failure admissions in the latest 12 months, and can perhaps be an indication of burden on hospital services. Perhaps community care is not working for these patients. So an indicator which may be helpful for strategic planning of heart failure services. This one goes on to look at heart failure in the population, and includes the Welsh Index of Multiple Deprivation to create a population-based view. Here we've got heart failure admission rates per 10,000 population, mapped by local authorities, the level we're looking at right now, but we can look by GP cluster and also by health board. And the chart in the bottom right-hand corner features admission rates for each of the health boards by deprivation quintile. So it goes from the most deprived on the left to the least deprived on the right. Which gives some sort of insight into the patient population and the variation in deprivation by health board. So these visuals, brought together can help with an understanding of a clinician's patient population. This is patient flows. This may also be important in planning services to see where patients are coming from. We can see in Wales then that 1.1% of heart failure patients are non-resident to Wales. Might also be interesting to look at how many Welsh residents go out to England for treatment. And the rest of the windows look at the movement between health boards in Wales of resident and non-resident health board patients. So health boards in Wales are responsible for the resident and their GP registered patients, but some health boards treat more patients from out of their own area than others. This might be down to regional services or rural communities where the nearest major hospital is in a different health board. So mostly on this slide, I think 6 of the 7 health boards on here treat people, non-residents, between 4 and 8%. But the one HB7 down there is taking nearly 30% of its patients are from out of area. So next we go on to the PROMs. As explained previously, there are issues with PROMs flowing nationally in Wales, partly due to multiple platforms within health boards with different levels of interaction with their local systems. But understanding the technical considerations required to enable this flow is something we are supporting, and we hope to provide a more complete picture of the use of heart failure PROMs in NHS Wales soon. So to date, we've collected just over 1,000 heart failure PROMs nationally. However, the majority of them are just from the One Health Board site. We can see just basic analysis on this, that 3/4 of the PROMs that were submitted were completed. And we will follow with further analysis on heart failure PROMs in subsequent releases. Okay, so this is the last slide I'm going to show today, which shows the completeness of fields with regards to audit for a number of key indicators. This would enable health boards to check their data quality with regards to audit at any point and have the chance then to improve it prior to submission. So that concludes the dashboard demo for today. No doubt it'll raise lots of questions. We recognise the importance of working closely with clinicians and the expert users. We want this to be a continuous process of improvement that will evolve over time. We're expecting the value of the dashboard to be more fully realised when we're able to link the PROMs to the existing activity and clinical outcome data. We want to work with our clinical reference groups to turn this data into useful information to drive this improvement. So I'm now going to pass you back to Jonathan, who hopefully will have less technical issues than me and will demonstrate in detail how they've started to do this. Thanks, John.
Yeah, I'm unmuted. Somebody nod. Thank you. Thanks, Sally. That's very good. And there are a few questions, Sally, that have come up. I think probably be wise to answer them now before we go forward. The first question that's come up from the audience was, will the data be made publicly available? Now, I think you did answer that in your talk, in so much that at summary level, health board summary level, it would be available.
Yeah.
But the heads of information and clinicians would decide about any public statements about the data. And then within health boards, there are filters for access to the the granularity of the data.
Yeah.
So in the sense that it's publicly available, I think the answer is not strictly, it's not, but any major outcomes or findings would, I think, with duty of candour, be made publicly available if it was felt by all to be in everyone's best interest to do that.
Yeah, we would.
Go on.
Sorry. Yeah, we would.
Yeah, carry on.
We would expect, we would try to make as much available publicly as we can, but obviously we are restricted. But any analysis, any aggregate analysis that we do could possibly be made available if that could show something that perhaps we weren't able to show at a lower level.
Okay. Another question from Anonymous, but firstly says it was an excellent presentation with clarity around the work you've done to complete the dashboard, and very good that WHC and DSCN are in place. But the question is, what arrangements are in place to work with the PROM data from the various digital platforms, as currently they don't conform to DSCN? So in Wales, we've got, to my knowledge, a couple of platforms that are being used clinically. Patient Knows Best was one, and Doctor is another. There may be more. But on those, they are hosting PROMs for heart failure. So at the moment, the dashboard's not able to access them. So what plans, if any, do we have to get access?
Yeah, this is something that we'll cover in more detail tomorrow in the talk on PROM standardization. But it is early days. We understand that we need to get access to that data on there, because there's lots of good work and hard work being collecting that data, and it would be great to have it nationally. But there are interoperability issues, and there are problems extracting that data even locally. So this is something that we are looking into currently, and hopefully got a proof of concept on the cards to extract some of that data from one of our health boards, from one of the third-party suppliers. Okay, thanks.
The question here from Alan Wardo, one of our colleagues, just saying that it's been taken a long time, he's not criticising us, to develop dashboards for a small number of conditions. He wants to know, in order to scale the pace of development, is there a strategy in place within Nhs, I guess, to scale up this? I'm not aware of it, but do you know anything, Sally?
Well, I mean, the more and more we do, the easier it's going to get, and the faster we'll get at doing it. A lot of the delay, not just COVID, prior to that, was around how we were going to publish, how we were going to make this available to everybody. We now have that through Power BI and the Office 365 agreement. But yeah, I mean, there's lots of issues, like we say, with the data, with the outcomes collection, all things that I think we're now getting on top of. There's lots of programs in place to start these pieces of work. They do start to feel like they're becoming joined up now, which is positive. So yeah, I mean, it should only increase from here. Obviously, we're guided by the clinical priorities of the programme, but each dashboard the development time for it should get quicker as we go forward. Mm-hmm.
I guess, yeah, the generic things you're doing, aren't there? The linkages, for instance.
Yeah, exactly. Yeah. Mm-hmm.
Another question, how significant a factor do you think the disruption of clinical coding on cardiac activity reporting has been during the pandemic? And the reason of it is obvious reason. There's a risk here when we try to do any impact analysis on current services. Do you think it's had a major impact?
I would imagine it has, yeah. To be honest, I don't know is the true answer. Been involved in other things at this point, but yeah, I would imagine it's had a huge impact. And we have the National Clinical Coding Manager for Wales that sits with us within information, and I know he said it's across the board it's caused a massive delay, but at this point I don't know what the true answer is there. I think this is something that we'll find out to come.
You mentioned that point when you were talking about heart failure admissions and saying that it had reduced significantly in 2020, and you mentioned it then, but what NICOR have shown through the pandemic is that heart failure admissions across England and Wales dropped by 66% during the first wave of the pandemic. And actually, they haven't gone back up. And what's happened is there's been a lot of innovation in the management of heart failure, a lot more very rapid up-titrating of drugs in hospital, and then very close community follow-up. So a big change, I think, in the pathway of care. So it may be that particular thing you picked up is a real effect.
Right.
It's just the pathways have changed, and it's due to innovation brought on by the necessity of COVID, because clearly patients with heart failure are at very high risk should they contract COVID. So getting them out of hospital is a priority.
Well, that makes sense.
The public also the public messaging about don't come in has been important.
Yeah, that makes sense, because it was the readmissions that dropped down, that we saw drop down. So, you know, people in, they don't want them to go back in, so they managed more in the community. Okay.
Somebody else has asked, would it be possible to use the data to progress clinical research? And RWE, I'm not sure what that acronym stands for, requirements, whether in academia, third sector, industry. Well, I'll answer from me and say, yeah, of course it is. It's a powerful tool for research. And even as I said at the outset, this is first iteration, and it's really a proof of concept that by using all those different data sources that Sally showed on the slides, you're able to pull out of it this information. What the clinicians will do when they get hold of this information now is start asking more and more questions, going back to looking at probably different information silos, different data silos to get a handle on what's really happening. And then, for example, in heart failure, there is, even from the Atlas data, there's a relationship between length of stay from the first admission and readmission rate. So the shorter the length of stay, the more likely a readmission. And because the data in the Atlas is incomplete, we don't know the real reason for that. The heart failure national audit would suggest that patients who have a short length of stay, who are looked after by general physicians, tend to have more readmissions. And that's partly due to the multidisciplinary team that the heart failure service brings, and the close follow-up post-discharge the heart failure service brings, and the likelihood is, with that heart failure specialist involvement, patients from the three major groups of drugs which reduce morbidity and mortality and readmission. So it's full of questions. When you see the dashboard as you presented it, it's full of questions, but it's exciting, and I think it's got real potential. Now, next one is from Stevie. I think maybe Stevie working now with the network with us, just started. Is there a working group developing this with the stakeholders? It's not a silly question. It needs a working group. We do have an expert reference group within the Welsh Cardiac Society who have been involved previously and will be involved going forward. But the main stakeholders in this are the patients. One of the things we struggle with in Wales is getting good real patient representation on a lot of the work that we do. And I think it's vital that we have that when we work with these sort of dashboards, no matter what the disease, that we have a very strong patient voice. Real world evidence, the RWE, thank you. And more questions are flying in. Might the service, this is for you, Sally, might the service be looking to partnership with industry around some of the innovations you mentioned in the previous question? Maybe to me then. I'll answer it because we've been working with the industry in the broader sense within heart failure innovations in practice, and we're working together with them with patient stories and with their own innovations, if you like, whether they're devices or whether they're drugs. So we are working with industry, trying to develop better patient pathways. So I think the answer to that is yes. This one's for you, Sally. Great presentation, and this is what value is really about. We can and do talk about theory all day long, but doing this and giving it a go in the real world with all the challenges is the difficult bit. And I would agree with it, whoever's commented, well done. Because it's easy to talk and say, get us a dashboard, put it all together, but you've done it. And I think it's the beginning of the beginning at the moment for this. Sorry, I can't read this last question because a message is joining away a bit. Right. Now, there was a mention of a program of clinical priorities regarding the scaling up of dashboard development. Is this work program published or available? And that's from Nicola Bray and Betsy Cadwallader, UHB. Do you know that?
Not currently. It's not currently published, but we do have a website that's been launched this week. And once we start to add more and more of our work on there, I'm sure it'll be appearing on there soon.
Okay. Well, we've run out at the moment. The questions have ceased. So I would just like, well, I've got everybody's attention. Just a signpost. There's a presentation in the Value in Health Week on Thursday, 2 o'clock to 2:35, on the innovations in the heart failure service at Swansea Bay, UHB. So if you haven't signed up for it, just make a note. I think it'll be useful and worthwhile if you're interested. So thanks, Sally. I've got about 10 minutes. I was going to just run back through some of the Cardiovascular Atlas work in a bit more detail about what we did and what we are doing. Now, the Atlas was published in March last year as a paper document, but actually it's a much better as an electronic document. And if you're working in Wales, and even if you're not, you can go on the link there. You can get the electronic version, but you can also use Health Maps Wales, which allows you to look at areas such as health board areas and look at all the data for that health board, which is really useful in terms of trying to encourage and drive changes in practice. So it's, to my mind, it's something that should be used as a tool to try and understand better where we find unwarranted variation. So next slide, please. Next slide. Very quickly, when we did it, jump back one. When we did it, there were a lot of people involved in developing the Atlas, but the important one there is Sally, as the Atlas support team, who probably lost a few years of her life trying to get the data to any shape or form that we could actually use. We also were helped in developing it by the Oxford Centre for Triple Value Healthcare, which is Samira Gray's team, and particularly Erica Eisen, who has written many of the atlases currently in circulation in England. Okay, next slide, please. And do a couple, I think it's a click, yeah. So what we set out to do, very different to most traditional atlases, was to have a patient journey. So start with the community the patients live in, look at their interactions through primary, secondary and tertiary care. Next slide. There's a bit of a lag, sorry. So within the communities, we were looking at things such as the social determinants and drivers of health. So globalization, urbanization, aging, income, education, and housing. We looked at behavioral risk factors such as unhealthy diets, tobacco use, and the harmful use of alcohol. And then we looked at metabolic risk factors such as high blood pressure, obesity, diabetes, and cholesterol. And ultimately, we looked at cardiovascular disease, the heart attacks, heart failure, strokes. Next slide, please. So taking all the risk factors, the social determinants, the behavioral risk factors, the metabolic risk factors, and how they combine in an individual who may be predisposed genetically, would then show the phenotypic signs and symptoms of cardiovascular disease. Next slide. So with this, with the whole atlas, we underpinned all of it with the Welsh Index of Multiple Deprivation. And this is the Welsh Government official measure of relative deprivation for small areas in Wales. So the maps show how we could do this. So the underlying map in the different shades of blue and white and grey are the areas of index and multiple deprivation. Overlying it, click, click and click if you wouldn't mind, 3 clicks I think, are the local authority maps, the health board maps, and then the one here on the inside left, the bottom, is the primary care cluster map. Next slide. So for those of you who don't work or live in the UK, and particularly who don't work and live in Wales, primary care is the family doctor, general practitioner. So the primary care practice is a multidisciplinary team involving pharmacists, optometrists, GPs, nurses, and they tend to exist in partnerships. There's very rarely single-handed. The size of practices vary from relatively small 3,000-4,000 population to large, much larger populations, up to 30,000-40,000. And the clusters are where geographically practices have combined. So we have 64 clusters in Wales, and this map shows the clusters. And the idea of mapping everything as primary care clusters for our atlas was that we could take everything back to where we have to, back to primary care, because that in essence is where all the patients start their journey if they travel forward into secondary or tertiary care. So one click shows the journey, sorry. Thanks. So that was the idea behind the structure. Next slide, please. So we looked at these risk factors: smoking, hypertension, obesity, physical activity, alcohol, diet, diabetes. Next slide. And we also looked at hospital admissions for 3 main things. One was chest pain, the acute coronary syndromes, one was heart failure, and the other was atrial fibrillation and stroke. Next slide. I'm just looking at the time here, I've got a couple of minutes. What we did, which I think again is unique in atlases, was to also look at the financial impact by costing the hospital admissions. Just do a click, please. And yeah, there it is. So this table is just showing the cost of patients arriving in a hospital with a non-ST elevation acute coronary syndrome. And it gives you a cost for Wales, bottom right, grand total of just over £20 million. But it's split by health board and it's averaged out. But the key thing is most of the cost is driven by the length of stay. And we knew, and we still know, that the optimum quality standard is to get these patients to an angiogram and an intervention within 72 hours. So if we were delivering an optimum pathway, we would be seeing these patients, treating them within 72 hours, discharging most of them at day 3, day 4. So just by optimizing the pathway on a value-based thing, a value-based scheme, patients would get better clinical outcomes. That's evidence-based, but we would get much better financial outcome as well. And the health economy in general would benefit because beds would be available. So we're currently working with one of the health boards on a national program. So the first health board, we're working with them to process map their acute coronary syndrome pathway to improve it and deliver where we can the optimum of 72 hours. And this is a a starter which is going to run through Wales and hopefully deliver much better outcomes for our patients and better financial outcomes for our health service. So if you like, value-based in action. I think, like most of you, if you're clinicians or not, you get the concept of value-based is fairly straightforward, very easy to grasp. And I work with cardiologists who tend to be reasonably cynical, who say, yeah, we get that, but so what? And we're now doing the so what. We're actually going out, not talking the theory, doing the doing, getting it done and seeing where we find, and I'm sure we'll find resource gaps in a pathway. Then this approach should allow us to reallocate money to fill those resource gaps. And key to success, in my view, is that we have executive board engagement, and even more key to that success is that the drivers are the directors of finance in the health board. So this is not a cost-saving exercise. This is all about getting better patient outcomes. And it just highlights to me that the dashboard approach, getting very good quality data, enabling us to answer the questions so that we can plan our services properly, we can have a proper strategic overview, is the way forward. And I'm full of admiration for Sally and her colleagues for the way in which they've addressed it and approached it. It's by no means the completed article, but it's really exciting. Okay, I think that's the last slide. Next slide. Oh no, I've got a few examples. Forgot. Yeah, so this is adults who smoke looking at risk factors on the right. There's a significant 2.5-fold difference between the lowest levels and the highest levels of smoking. And on the left-hand side is the correlation with deprivation. And the higher the deprivation score, the more likely you are to smoke. So there's a very strong positive correlation. Next slide. And similarly, if you've seen smoking, this is coronary disease. The maps look very similar. Same areas of high levels of coronary disease. And click, please. And again, there's a very positive correlation with deprivation. Next slide. And I think Sally's touched on this. This is heart failure emergency readmissions, and this is data from 2016-17. Same story though. Shorter length of stay is linked to increased hospital readmissions. But there is a significant variation in that, and this map does not tell us why. This map just tells us there is variation, and our next job is to try and understand why there's variation. So the idea of the atlas is to bring these things to people's attention and make them look and find out why there is variation. And I think the dashboard will do something very similar. Okay, next slide. Yeah, cool. And that's my last slide, actually, just giving you the link again, if anybody's interested and wants to look at it. But I'd recommend when you get onto the website, you look at the electronic version, but also the Health Maps Wales, which allows you to look at health board by area, which is quite interesting. Okay, well, thank you. I'm going to quickly check any further questions. There was a question which I'll answer. When will the data be refreshed in the Atlas of Variation? As it currently is, probably 2018 is the latest. I think, in my view, if it hadn't been for COVID, I would have been pushing very hard for it to be looked at again next year. It does need to be done again, but perhaps in a more targeted way, not all the different indicators we used in the Atlas, but perhaps specific ones. But actually, I think the plan initially was to roll the Atlas approach across all the specialty areas in Wales, and I still think that would be a valuable exercise. So I think we're reaching end of time, so I can't see any other outstanding questions. Just checking, Sally. Yeah. So I'd like to thank Sally Cox again for all the hard work she's put in and for doing the presentation today. And I'm really looking forward to working closely with Sally in the future to develop the dashboard. And I think the dashboard will drive much closer clinical engagement, and particularly better clinical engagement in actually recording the data we need. So unless there's any further questions. Yes. Okay. Yeah, there's a slide coming up just to remind you to have a look at what else is happening this week. There's many different things happening in the Value in Health Week in Wales. I hope you've enjoyed today's session. I'd like to thank all the backroom staff, Alistair Wood particularly, and Priya and Sarah Plutoni for putting this together and actually making it work. So thank you, and goodbye from me. You're on mute, Sally.
Oh, goodbye from me as well. Thank you.